It's 18:02. As I've said, we're gonna start. Good afternoon, colleagues, and welcome to our second monthly RAMP webinar. Thank you for taking your time, colleagues, to join us today. As we know that this webinar is aligned with the World Hypertension Day, which was commemorated on the 17th of May, 2026. And we are pleased to have you with us to continue these important learning conversations for clinicians who are working in the rural and underserved settings. So before we begin, colleagues, I would like to go through some few house rules. Please keep your microphone muted during the presentation to minimize the background noise. If you have any questions during the session, please post them in the chat box. Questions will be answered at the end of the webinar during the Q&A session. And if you prefer to ask questions verbally, please you raise your hand. You use the raise hand function and we'll unmute you when it's your turn to speak. So to qualify for this one CPD point, please remain in the webinar for more than 45 minutes. CPD attendance will be submitted by the Rudasa admin team, so there is no need for you to submit anything separately. There will be a poll at the end of the webinar to collect the details required for the CPD submission, so please make sure you complete it before leaving. Please ensure that you have your name and your surname in the screen so that we can recognize you. So all these Rudasa webinars, they are recorded and they will be made available on the Rudasa YouTube channel, so you can revisit the session or share it with the colleagues who were unable to attend. And once again, thank you, colleagues, for joining us, and we hope you find today's sessions valuable and engaging. So now it's my pleasure to introduce our speaker for tonight's session, Professor Andy Parrish, who is an associate professor in the internal medicine at Walter Sisulu University and is based at Cecilia Makiwane Hospital in East London. He is a specialist physician with a long-standing interest in evidence-based medicine, clinical pharmacology, clinical epidemiology, and health technology assessment. He has also contributed to the South African Essential Medicines List Committee since 2010, with a keen interest in decision-making and guideline development. So Professor Parrish is also passionate about teaching, outreach, and mentoring doctors who are working in rural facilities, particularly in Buffalo City Metro and Amathole District in the Eastern Cape. So tonight he will be presenting on the update on the management of the DVT and pulmonary embolus, the use of the DOACs, which are direct oral anticoagulants. This is a very relevant and practical topic for clinicians working in the rural and district health settings, where we need to do a timely diagnosis, safe anticoagulation, referral decisions, and follow-up, which are the critical parts of patient care. So, Professor, thank you very much for joining us and sharing your expertise with the RAMP and Rudasa community. We are honored to have you with us. I will now hand over to you, Prof.
Thanks, Mpolisi. It's a pleasure to be with you guys, and I hope there's some useful pointers here in quite a large topic, but I hope to go through some of it, not cover everything, obviously. The agenda basically is to give you a little bit of background on venous thromboembolus as a subject, but I won't spend long on that because I'm sure you know it all very well. And then talk about treatment of DVTs, a little bit about VTE prophylaxis, and themed throughout both of the previous topics will be medication for it, but focusing mainly on the newer agents. So the background of DVT or venous thromboembolism is that it's a combination of three issues, either endothelial issues with a sticky pipe or flow problems with a blocked pipe, or a thrombophilia, which is sticky blood. And in the sort of developed world, the risk factors that I've identified as most important are surgery, immobilization, and malignancy. In low and middle income countries, there's other challenges we have to look at, as there seems to be quite clear associations with severe HIV infections, TB, and possibly also malnutrition. So the sort of key slide in terms of the numbers is that pulmonary embolism is a horrible condition. You know, it has a mortality rate of up to 20% in some studies. It obviously depends on how you define it and how you look for it. About half of the venous thromboembolisms that one sees are unprovoked. In other words, there's no clearly identified risk factor. And sometimes the provoked ones are also associated with other risk factors that aren't quite as obvious as the one straight in front of you. So it's a mishmash of things that can cause it, but the recurrence rate after an unprovoked venous thromboembolism is about 25% if you follow people up for a decade. So it is something worth thinking about. The sort of good news about it, though, is that the sort of bad outcomes type thing from recurrences isn't quite as high as you might think. So if you've stopped anticoagulation after an unprovoked DVT, the recurrence rate is about 6 per 100 person years. You think of it as 6%. And the fatal recurrence rate is a whole lot smaller than that. So it is something that we treat with a great deal of respect, but the numbers are important, and it is quite worthwhile thinking a little bit about them, and we'll come back to that in some detail. So I'm just prefacing what I want to say with some caveats about the data. It's very weak on natural history. It's weak on risk scoring systems outside affluent countries, although we'll touch on that. It's weak on the efficacy of heparin, oddly enough, for some of the indications. The low molecular weight heparins and the newer agents have much stronger evidence, and we'll come to that also. And the reason is if in the bottom of that slide where you can see that it's expected that the global revenue from selling these agents is going to be of the order of $50 billion per year in 2027. So it's a big topic in terms of money, but it's also an important topic for patients and for us. All right, so my EML hat, which has now come off since I've retired from it, is there on the left. If you're looking for EML documents nowadays, they are a little bit hidden. So I've given you a website to look at, but the clue is to go to the NHI section of health.gov.za, and underneath that you'll find a not particularly user-friendly screen, which at the bottom there on the right you can see it says hospital level adults. And that document, after much persuasion, now changes as new information comes about. So it's available as a PDF, and every time they update it, and the last update I think was in March this year, they put a new PDF up for you to either download or peruse on site. So the concept is that the stuff is more recent than the old-fashioned books that we used to have. But have a look there, you might find something of value there. So DVT basically is a issue around looking at local versus embolic complications, and the management really is about preventing embolization and preventing recurrence. The drugs we've given don't really do much about removing the thrombus, and I'm not really going to spend time talking about thrombectomy and clot lysis in this presentation. So there's what can go horribly wrong with these things. They're not always a simple swollen leg which settles down with a bit of treatment and all is well. Sometimes they can actually end up with quite nasty sequelae, and it is worth thinking about avoiding these things. There's a differential, of course. And the calf muscle tear is the one that you should think about. Abrupt onset in the history obviously usually gives it away, but occasionally people forget to mention it, or everybody's so keen to call it a DVT that they don't recognize it. And obviously that's one that really does very poorly on anticoagulation. I've seen them balloon up with hematoma formation if you give a ruptured gastrocnemius some anticoags. So just be careful of that one. The Baker's cyst is relatively straightforward. Again, if you think of it, usually relatively longish history, but can be abrupt if it pops and there is a swelling or something on ultrasound behind the knee. Superficial thrombophlebitis, and that's number 3 there, is not a DVT. A superficial sort of spreading thing along the veins is not quite the same thing and hasn't got the embolic implications of a deep thrombosis. And then obviously chronic venous insufficiency you've all seen and know, so I won't spend any time at all talking about that. Cellulitis is one of the things that can be confusing and is worth thinking about whether it is a DVT or a cellulitis, or sometimes both. And then the last one in the corner there, number 6, is a lymphedema issue, where again, it's all in the history and quite straightforward if you think about it. I have had this referred to me with a history of swelling for a decade, and people thought it was a DVT. So take the history and you should be able to get away with it quite easily. The diagnosis is actually always something to get a little bit cautious about in terms of the traditional signs and symptoms that we've been given. So at the top there is a whole thing on sensitivity of these various signs. Homan sign, as you can see, is useless. Don't worry with it. It does not help you. And if you look at the bottom on the right, you've got a little color diagram, which is a thing about likelihood ratios. I'm going to come back to that, so I'll spend a little bit of time on it. So likelihood ratio of 1 is a test which has no influence on your probability of the disease being present after you've done the test. It's useless, basically. If the likelihood ratio is 2, and it's calculated from a combination of sensitivity and specificity, you increase your probability by 15%. So if you were 50-50, and the likelihood ratio of your test is 2, and the test is positive, you now have a 65% chance that person has that disease. If you were 50-50 and the likelihood ratio of the test you apply is 10, you're now pretty close to certain. It's 95% certain, because you just add those two things together. All right. So where you sit there with those things is that they're horrible. Okay, so the symptoms and sign type things are pretty useless. They all have likelihood ratios of 2 or less. And that means that they're not good for ruling in a DVT, and not particularly good at ruling them out either. So just be careful. The other thing that people think is you can just do a CRP, and people with a cellulitis will have a raised CRP and people with a DVT won't. Well, as you can see, your CRP goes up with a serious DVT, and it goes up for a few days, and certainly is not a reason to say a patient has a cellulitis just because the CRP is up. Both of the conditions will do that. And then finally, we come on to the sort of fairly straightforward stuff that is where we are these days. The D-dimer, firstly, it rules out a DVT. It doesn't rule it in. So if you've got somebody who's sitting in your emergency unit and you're wondering whether they've got a DVT and your D-dimer comes back as negative, it makes it very unlikely. If it is positive, it doesn't mean it is a DVT, though. You can a bunch of other things that can cause a positive D-dimer. And then obviously the useful thing is some form of calf ultrasound, either with Doppler or without. But if you see a non-compressible vein, and if on Doppler, you can see something stuck in it with flow around it, you're probably in business. So it's worth thinking about whether that's a skill worth acquiring if you haven't already done so. It is a very useful, extremely quick way of solving a problem which otherwise causes a lot of head scratching. So the last thing then is to look at these scoring systems. And I'm not going to spend time on this because it is something that you're all probably familiar with. And I'm not that impressed with where we are with them. And I'll show you why. But basically, they were all developed in first world countries. And I'll come back to that. And they use a combination of those things to give you a point system. And if you're above a certain number of points, then you cross a threshold for a diagnosis. The problem with it is that we get back to this graph, or this table again of the likelihood ratios. And the issue is that a D-dimer, as you can see, if it's positive, sways you a little bit. If it's negative, it's very helpful. So a D-dimer with a negative likelihood ratio of 0.13 is a fairly good excluder of illness. But all of the Geneva rules and the Wells rules don't perform particularly well. They're not horrible, but they don't solve your problem for good, whereas lung imaging effectively does. If the lung imaging is negative, and we're talking about CTs and things like that, then it would be, the CT angiogram that's negative probably it rules it out. A CT angiogram that's positive is obviously very helpful for pulmonary embolus. Just a very brief detour via a study done in Kenya, which basically says that the folk we're seeing in our practices are not necessarily the same as those seen in affluent practices in Europe and America. And essentially, they have less cancer and a lot of sort of similarities otherwise, but the sort of not particularly useful signs, there's leg swelling and the calf swelling, which could be other things, are common, and the alternative diagnosis and the presence of recently being bedridden and having cancer are perhaps not as common. When it was looked at in the sub-Saharan population, these scores didn't perform particularly well either. So there you can see, I haven't calculated the likelihood ratios, but with sensitivities and specificities of the order of 50 or 60%, they don't perform well. All right, so what happens if you take TB and HIV and give them a point in terms of your score? Does it improve things? Well, in terms of sensitivity, yes, it does. If you look at that column on the right, this was a study published a few years ago in the South African HIV Medicine Journal, and it basically says people with active TB who have a sort of swollen leg of sudden onset while they're lying in bed have a high chance of having a DVT, which is not a surprise, but it's basically is a modification of a Wells score, which might be a useful thing to think about. So add a point each for HIV and TB, according to these authors. I'm not going to spend long talking about pulmonary embolus, and this is the last sort of prelude slide before we get onto thinking about management in a more sort of detailed way. But basically, it's the things that are fairly classic: abrupt pain, breathlessness. There may be nothing to find on examination. There may be a rub occasionally if you listen, but you have to listen fairly carefully. So a pleural rub suggests that there's a pulmonary infarct that's abutting on the pleura. There may obviously be hypoxemia on your pulse oximeter, and occasionally they present with florid pulmonary edema. And I think that's an important thing to just have at the back of your mind. And a really abrupt onset of flash pulmonary edema, pulmonary embolus is one of the differentials for it. There are a few other things, but certainly don't ignore the possibility just because somebody has lots of crackles that they could have a pulmonary embolus as well. A few years ago, everybody was going on about how if you had exquisite pain on tenderness and tenderness over one point on your chest, it effectively excluded a pulmonary embolus. That's not true, and we've known that for almost a decade now. A large study on pulmonary thromboembolic disease done in France basically found quite a high proportion of patients had chest wall sensitivity, so it does not exclude the diagnosis. The classic ECG of an S1Q3T3 you've all seen. Very rare, 90% of patients with a pulmonary embolus don't have that. They might have a changing axis, so it might shift right and then shift back again if you do the ECG twice. Echocardiography can be helpful. Right ventricle is dilated, high right-sided pressures, obviously. We've talked about the D-dimer, but I won't spend longer on that other than to remind you that positive D-dimers may be false positives. And then just because they have a positive troponin doesn't mean it's a heart attack. People, it's such a common finding to have a positive trop in a pulmonary embolus that it's actually used as a prognostic indicator. So be wary of that one. And then obviously the CT angiography is the thing that is very helpful in terms of a definitive diagnosis, but we're probably over-diagnosing subsegmental pulmonary embolides, the indications for treatment are a little moot. All right, so I'm going to go straight on to the nitty-gritty of treating a proximal DVT or a pulmonary embolus according to the EML guideline for the public sector in South Africa. We made it very simple. It's rivaroxaban 15 milligrams twice daily for 3 weeks, and then 20 milligrams daily for 3 months. It's in the handbook there, and it's a fairly standard sort of dose. It starts working within a couple of hours. And when you stop taking it 24 hours after the last dose, it's out of the system. And it's important to remember when you use this stuff, it actually isn't readily reversible. So once it's in, and you have to think very hard about the reasons not to use it, and I'll come to that in the next slide. But basically, it acts on factor 10A, and it is givable via a nasogastric tube, which is that middle picture. It is well absorbed if you crush it, which is unlike a whole lot of the other medicines which we crush and bung down a nasogastric tube. So it is worth knowing that, but let's talk about the contraindications next. So they're fairly obvious when you think about it. I mean, if somebody's actively bleeding, don't give them an anticoagulant, but also think about people who have a high risk of actively bleeding, those with chronic liver disease, peptic ulcer disease, coagulopathies of any sort. And if they're already on some form of anticoagulant or antiplatelet therapy, just be careful. Try and avoid it in people who've recently had eye or brain or spinal surgery. And by that, I mean in the last 24, 48 hours, obviously until they've stopped bleeding and a clot has formed. And be careful if somebody needs a lumbar puncture or you think somebody might need a lumbar puncture, just be careful of bunging the stuff in. You can't reverse it for another 24 hours. And obviously, if you're again thinking about a spinal anesthetic. And don't give it if the GFR is less than 30 mils per minute, or if there's uncontrolled hypertension. Uncontrolled hypertension, of course, is one of those things that you can define as you like, but clearly it's somebody with very high blood pressure, sort of evidence of hypertensive retinopathy or anything to suggest that they are at risk of an intracranial bleed if you give them an anticoagulant. Here are some more contraindications. This is pulled directly from the EML handbook. That's that PDF I told you how to access. But pregnancy and lactation are important ones. People under the age of 18 and over the weight of 120 kilograms or with a BMI of more than 40. And we've put in age greater than 65 years, simply because the data in this patient population is quite weak, not because we don't expect it to work. You have to be cautious if you use it in elderly people. Obviously, if you have potential for pulmonary hemorrhage or previous bronchiectasis or have a known hypersensitivity to the stuff, you won't give it. The last one there on the right is something to just think through. Ritonavir will increase the amount of available rivaroxaban in the system in the sense that of enzyme inhibition. And the end result is that you can become more leaky. And ketoconazole, those are the big two that we come across. The ones that are doing the opposite are phenytoin, carbamazepine, and rifampicin. And rifampicin obviously is the key one to be interested in the sense that a lot of our patients have a active TB as one of the precipitants of their DVT. So at the moment, the jury is out about whether you can use it. There's very weak cohort evidence coming through that maybe it's not so bad, but for the record at the moment, just be careful. It's a real interaction, and ideally use something else other than rivaroxaban if somebody's on TB treatment. You would be then putting them on heparin and warfarin. The concept is that on warfarin, you can monitor the INR and find out what's going on while they're on rifampicin. All right. So just to remind, I mean, this is not new, but if rivaroxaban is contraindicated, or if you're going to anticoagulate for more than about 6 months, and this comes in because of economic factors, the cost of the stuff, use warfarin after initial enoxaparin, the subcutaneous 1 milligram per kilogram or 1.5 milligrams per kilogram per day. It's 1 milligram per kilogram 12 hourly. Or 1.5 daily will probably give you about the same thing. And the reason there's 2 doses there is because of optimizing vial usage. So, think about it. It's not every patient in the system weighs 80 kilograms. And please remember that. You can easily overdose these folk or underdose them. So try and get a weight and work it out so that you optimize the vials and don't break too many or waste too many. If the INR is between 2 and 3 after about 5 days of treatment, then it's safe to stop the enoxaparin and carry on with your warfarin, assuming you're on warfarin now. And then if you've got renal impairment in your patient and GFR is less than 30 moles per kilogram, the enoxaparin dose is daily rather than twice daily. So just a couple of thoughts about the events that you get when you are thinking about stopping the stuff. Now, the trouble with it is that when to stop your anticoagulation is always a bit tricky because there is clear evidence that there's a sort of rebound. After you stop anticoagulation, whenever you stop it after 6 months or after 2 years, there is a rebound in the risk of a recurrence, but these risks are not that high. And as you can see, the recurrence rate is a real thing. It will happen, and it will increase if you discontinue the agents. But the bleeding risk will also carry on accruing the longer you stay on these things. I'll show this in another way in this slide, which basically looks at the incidence per 100 person years. And this is from a relatively recent study, which basically said if you have no risk factors, first, that's that on the graph on the left, a solid line, the incidence per 100 person years is about 4. So sort of a 4% chance of a recurrence per year doesn't really change that much. And if you follow people up over 5 years, the probability that they will have a recurrence is of the order of 6%, 10%, as I've said before. It obviously will depend on other risk factors. If you have malignancy or something like that, that risk does go up. So here's the last one on this business about when to stop. It's from a BMJ article about 6 years ago now, 7 years, and they looked at all the studies that came out. I don't going to spend long on it. There's too many numbers. But if you just look at the 5-year cumulative incidence, it's the same as in that graph I showed you, about 25%. And after 5 years of having another event, and those events vary. So they are much less likely to be pulmonary emboli than DVT, but they're still very real and still possible. And a fatal pulmonary embolus has a 1% chance in the 5 years after a event, unprovoked VTE. So it's not that high, but it is obviously a very real number, and it is something that we're very concerned about and think quite hard about when you consider whether you want to stop treatment or not. So it's the sort of standard teaching, and again, as I've shown you those slides just to show you how tricky it can be to work out what to actually say, is if it's a provoked DVT like TB or something like that, or a long taxi ride, 3 months. But the issue is it says longer if unprovoked, but how long that should be is anybody's guess. And the main thing is that bleeding risk accrues constantly, so it keeps on going up the longer you stay on it. And we're talking here about people on warfarin now, if you're going beyond 6 months. And so our ability to control INRs and warfarin in South Africa is not particularly good. And I think this is a real concern that a lot of us would be worried about carrying on for too long, particularly if it's being difficult to control somebody's INR stably. The pulmonary embolus is theoretically the same condition as a DVT, so theoretically the advice is about the same. I'm going to move on very briefly to just talk about VTE prophylaxis in medical patients. There's a lot of issues around the data here, and I'm going to spend a few minutes just reminding us where we stand with the information that we have available. But I'm not going to spend too much time talking about non-medical patients, but I'll just briefly mention them. So predisposing risk factors for a VTE in a hospitalized patient basically would be older age, higher BMI, and then chronic conditions like heart failure, nephrotic syndrome, HIV, TB treatment, malignancy. On top of that, you have things that can happen. So, people who had a stroke, people who've got decompensated chronic lung disease, people in ICU or with severe sepsis, or other debilitating illness are at increased risk of having a VTE, and obviously the surgical folk as well. So people have got these scores again, and the trouble with these scoring systems is again, they're a bit shaky. So I'm just putting this slide up, not so we can go through it in detail, but just to remind you of some of them. There's Padua and there's the Improve VTE score, and they basically all look at a cutoff and the risk of having a VTE and the risk of bleeding. And if you look at it, I just drew this to show you how it works. So for Padua, if you've got a score of more than 4, you have a 10% chance of a VTE while in hospital. And the rate with prophylaxis drops to about 2%. So it does seem worthwhile. And the bleeding rate on anticoagulant is about 2%. So it seems worthwhile. Okay, you've got a 10% risk without anything, and you've got 2% risk with prophylaxis, but your bleeding rate goes up to 2. So you've halved the rate of a complication if you combine clot and bleed. But it's difficult sometimes to identify which patients are which, and I'll show you why. So improve it divides those things up again. If your improve it scores more than 3, 6%, and if the bleeding score is more than 7, you've got a 4% chance of bleeding. So you can see how those things can't really be equated. A clot and a bleed are not necessarily the same thing, but for convention, they have been seen as being similar. And here's one study, and I put a lot of stuff out here, but really just to show you that in this study, which actually isn't that easy to read because a lot of the patients did get anticoagulated. So it's not, it didn't perform well though. So these things were really not doing well. Look at those likelihood ratios down there, close to 1. That blue line, and it's something to really is food for thought when you think that this is how we set up our ideas around thromboprophylaxis. Here's another study. They're both cohorts. This one was terrible because half the cohort received prophylaxis. So how this thing performs is basically saying, you know, you're at higher risk, but this is in a group of patients, half of whom got anticoagulation anyway. But again, showing that they did not perform that well as risk predictors. This slide I'm just put up again to show you what happens if you give prophylaxis. So just look at the dark blue ones. This is a group of folk in whom more than 75% of patients got prophylaxis, and the event rate in that group was well under 20, about 10%, and sorry, the VTE event rate was about 5%, 6%, which is what we expected. The bleeding was what you expected, and the total events were sort of about 10%. So this is real stuff. It's important to know about it, but it's not as if bleeding doesn't happen. It is an important concern when you're putting this proportion of your patients onto anticoagulation. And the last thing I want to show you is really how troublesome some of this literature is. This is a Chinese study, but it's a system and network meta-analysis. And I'm just putting it there just to show you the pretty pictures. And the first pretty picture is this. The darker the line, the more evidence we have. So we know lots about the one on the right is about prophylaxis. And as you can see, it's really weak for some of these things versus low molecular weight versus placebo, we've got some data on. NOACs versus placebo, we've got even less data on. Just because there's a study doesn't mean it's a good study. And this comes out from this final table here. So the bottom table is prevention, and the pink bit is the quality of our information on how good we are at preventing DVTs in patients given prophylaxis with those various agents. And when it's pink, it's basically saying we're not certain at all. So green is happy and relatively sure, pink isn't. And as you can see, it's pink across the board for prophylaxis from this particular study, which is not saying one mustn't do it. It's just saying that the evidence is still maturing in terms of how effective it will end up being once the dust has settled. So if you are hospitalized with a high risk of DVT, it's still recommended to give rivaroxaban, and the dose will be 10 milligrams daily for the duration of the hospitalization or until the risk factors have reversed. If you can't give a NOAC, you can go back to what we've been doing a lot of anyway, which is to give 40 milligrams a day of subcutaneous enoxaparin, or 20 if your GFR is less than 30. And so in summary, I'm going to stop here so there is time for questions if there are any. There's relatively good evidence for using rivaroxaban to treat DVTs. It's probably as safe, if not safer, than our previous regimens. It is, oddly enough, no more expensive if you include all the bits and pieces, and only treat for 6 months. And it is, like any anticoagulant, a powerful agent with quite severe side effects in terms of uncontrollable bleeding if given to the wrong people. and it isn't easy to reverse it, and you have to wait until it's worn off, basically, which will take about 24 hours. But it is a reasonable thing to use to treat your DVT once you've diagnosed it and to make sure you are giving it to the right patient. The risk and benefit for prophylaxis is less certain, but I think that for most of our, patients who are sort of bedridden and relatively ill, they will clump home quite easily in terms of scoring on those um, risk scoring systems. And just remember that not everybody who's admitted to hospital needs prophylaxis. I mean, somebody who's wandering around the ward being investigated for some other non-inflammatory process really doesn't need anticoagulation. So it shouldn't be given to everybody. But if you do some form of risk score, you should write it down. Say, I think the risk score would be about this, or this is the risk factor that would justify giving this agent. It is then reasonable to go ahead and give your lower dose rivaroxaban. So I'll stop there and leave it open for questions and thoughts and comments. There is some time to do that. I can talk about other things like how to use warfarin, but I'll leave it at that for the moment. Thank you.
Thank you so much, Prof, for the wonderful presentation. It was very helpful. At the moment, I don't see any questions in the chat box. Colleagues, if you have any questions, you can raise your hand. Then I will unmute you, or you can write in the chat box. My question, Prof, is with warfarin, it's not wisely to use it with the high dose fluconazole. I've seen it when in some patients, those patients who have it's either the cryptococcal antigenemia or who are being treated for cryptococcal meningitis, that the warfarin, actually the patient will end up having the toxicity when they're on high dose fluconazole. So is there anything, any studies about the use of the rivaroxaban with the high dose fluconazole?
Yeah, so the trouble with any drug that you use with an anticoagulant is that the data is actually a lot weaker than the recommendations sometimes seem to suggest. And when you start to scratch the surface, it gets tricky. The bottom line of it is know which drugs interact with warfarin and with rivaroxaban. It's not difficult. It's in the SAMF and it's in our EML book as well. But if you're in any doubt, look it up. I mean, you can Google it if all else fails, and just find out if there's an interaction. It's simple as writing those three words, interaction and the two medications names, and you'll get something to help you. So if in doubt, look it up. Don't assume there isn't an interaction. And there is such a range of different medications that interact with both warfarin and rivaroxaban that you just have to be careful rather than say you can't use one versus the other. My standard teaching always with anything you're adding to a patient on warfarin is check the INR when you start and then check it again 2 or 3 days later. That's how long enzymes need to induce, and you generally will see which way things are going and can adjust accordingly. It's better than trying to work it out in theory, because in theory, everything goes out the windows when you add in a study that I was sort of vaguely involved in some years ago, which is the genetics behind warfarin metabolism. And they almost got to the stage now where you can do this as a bedside test. But until such time as we know what sort of genes you've got, predicting what is going to happen when warfarin interacts with other medication can be tricky. So the short answer is beware of nearly everything. My sort of one that I keep on reminding people of, which for me is often more torrid than fluconazole, is quinolone. So any quinolone, but ciprofloxacin and floxacin certainly will interact with warfarin in a massive way, and your INR will shoot up. I've seen people exsanguinate because of that, literally drop their HBs down to 2 because folk haven't thought of the possibility that the two things could be doing that. So yeah, it's not that you can't use these things, even though they say you shouldn't, but if you are going to use them, do it with your eyes wide open. And that's the difference between rivaroxaban and warfarin, and why rivaroxaban isn't a good idea, because you can't predict it, because the testing for its efficacy is much more arduous and costly than simply doing an INR and warfarin.
Thanks, Prof. There's some question in the chat box. So the colleague is asking, is rivaroxaban available in the state sector?
Yeah, look, the short answer is we put it on code 2 years ago. The intermediate answer is that it does depend on your local pharmacy and your local depot on how available it is at an individual hospital level. But certainly the reason we put it on code is because it was saving money, and it actually would save a huge amount of money if people started to use it. And the fact that it's on code but not being used means that that's benefit isn't quite there yet, but it certainly is available. Yeah.
Okay, thanks, Prof. The other question that we have here, the colleague is asking, other than warfarin, is there any other alternative to rivaroxaban for in older people?
Yeah. So again, it depends on where you're working. In the private sector, yes. In the state sector, we've got the enoxaparin option, which is obviously injectable, and it's not something you want to use long term, and warfarin and rivaroxaban, which are the only things that are readily available. Every now and then we can make a case for something else, but the bottom line of it is that warfarin is doable in elderly people so long as you're aware of what you're doing and keep an eye on the INR. And mostly it's predictable which way it's likely to go. And you can keep elderly folk on it for years. I had one old gentleman who had a valve replacement, who had a rock solid INR of 2.4 for 20 years. He just didn't budge his INR from that beautiful figure. And it's simply a question of a combination of a health system that doesn't run out of the medication, ability to get the INRs checked regularly, and just keeping an awareness of other medication or foods that people can take. So remember that as we head into winter, the availability of green leafy vegetables becomes less, and INRs tend to change a little in winter.
Are you still here, Prof?
Yeah.
Oh, okay, thanks. Thank you so much, Prof. I think there is a lot of questions now. I think there is a hand that is up. John, hand is up. I will unmute you. Please unmute yourself on your side, and you can go ahead with the question.
Thanks, Prof, for the presentation. My question is, when is this safe to stop anticoagulation on patients with recurrent DVT, where serial Doppler has shown that there are still clots, meanwhile this patient has been on treatment for a long time? When is it safe to stop the anticoagulation? I don't know if you got my
Yeah,
question.
yeah. I think I got the question. I'm just going to repeat it back to make sure I understood it. So you're talking about people with recurrent venous thromboembolism and whether or not you would stop anticoagulation in that situation. I mean, the issue really is that a recurrent venous thromboembolism is saying something about risk factors. And unless there are reversible risk factors in that situation, which is rare, but does happen occasionally, you then would be looking at long-term anticoagulation. And it nearly always falls in favor of giving long-term anticoagulation unless you have a patient with a horrific has bled or other bleeding risk score uh, profile. And those folk would be people who just can't take the medicines regularly, who alcoholics and who, are bumping themselves all the time or whatever. But in most other situations, it makes more sense to keep that person on anticoagulation. So the other question on the chat was about, can you discharge people on enoxaparin? Certainly, that's really our only option for pregnancy. And I haven't discussed that at all here, simply with time constraints. But that would really be where we'd be heading for patients who are requiring anticoagulation in pregnancy, would be to use enoxaparin. As you can use it as an outpatient. It's no more difficult to inject than insulin, so it can be done. But obviously, it's a very pricey issue to give it long term. So one has to be careful, and also you have to be a little bit careful of giving any anticoagulant like that to folk who struggle with dosing and knowing how to inject.
Thank you so much, Prof. I think there's one last question. Just want to make sure I'm not skipping it. That was asked by Ompile. The colleague is saying that the biggest question or concern is stopping or halting of anticoagulants. Should it be stopped by the physician or specialist? So this is a more practical base for clinicians who are working in clinics and district hospitals.
Yeah, it's a good question, and I don't think it has to be stopped by a physician. I mean, you just have to do the risk-benefit thinking and discuss it with the patient. So if you have somebody who has had an a provoked DVT, they were traveling in a taxi for 12 hours, their feet were all cramped up, and then, as they got out, they had a sore leg and it was all swollen and bob's your uncle, and they're a young person without other risk factors. 3 months of anticoagulation is fine. You can tell the patient that's what you're going to do and stop it. And that's the end of the story. Once you start to get in sort of unprovoked DVTs and people who have ongoing risk factors that are, balancing in favor of continuing, there is a case to be made for carrying on. And that's where these sort of magic equations or formulae of counting the number of points they get help you think about it. Although, as I've said, they're not very reliable at all. My simple approach to it is to turn it around. If you have a patient who's really struggling to keep their INR constants, it's yo-yoing all over the show. It's 1 and then it's 4 and then it's 2 and then it's 5 and then they come in with a bleed. That sort of patient, I would be inclined to stop unless there's a very compelling reason to carry on. And if they are absolutely creaming it and finding it really easy to do, and in that situation, you can make a case for continuing longer. What you often find, though, is that patients will also express a preference. And, the preference is related to the experience they had with their first event. So somebody who had a relatively minor swollen leg and was inconvenienced for a week in hospital will feel less strongly about it than somebody who had a life-threatening pulmonary embolus. The latter patients, even though their chance of having another pulmonary embolus is outweighed by their chance of having a standard venous thromboembolus in a leg, is still that those folk feel quite nervous about it, and understandably so, and they tend to want to stay on treatment. So, being sensible about bleeding risk and being listening to your patient will probably allow you to get away with most of it. There's no law that says you can't stop it. Some people do a D-dimer a month after stopping treatment, and if that's elevated, that would be an indication that you may want to pop them back onto treatment, and you could negotiate with that with a patient. But it's very difficult to say, I'm stopping your treatment, I'm going to do a blood test in a month's time, and we'll talk again. You have to have that conversation right up front and say, look, if it is up, then we will want to put you back on. How do you feel about that? And once that discussion has happened, I think it's one option. But generally speaking, patients and bleeding risk solve most of the issues.
Thank you so much, Prof, for this very interesting and interactive session. I'm not seeing any questions now. Thank you, Prof, for joining us and giving us this talk. It was very, very useful, and I hope colleagues will start now checking at their pharmacy and starting using the direct oral anticoagulants for the patients who are qualifying to go on them. Thank you so much, Prof.
Thank you, and thanks for all of you for popping in and listening. It was great having such an entertaining audience with such good questions. So enjoy your evening further, and good luck with your patient care. Thanks very much. Cheers then.
Thanks, Prof. Colleagues, today I can't pull up the poll. The admin will send the poll through your emails that you registered with for the CPD points. Thank you so much, colleagues, for joining this session. See you the next monthly RAMP session. Thank you, colleagues. Have a good evening.
Thanks, Mfulisi. Cheers then.